2025. We have about 5 separate cases today. So we'll get started. We're going to start with medicine unit 2, 3, 4, 5, respiratory medicine, and if we have time, medicine 1. So we'll start with the first case from medicine unit 2.
Starting with the case, 36-year-old female Mrs. X from Budiatam. She had a history of, on 13th of December, she had a history of unknown bite in the left foot, followed by a transient drooping of bilateral eyelids for almost 1 day, and was damaged. She went to the hospital and she was damaged from the hospital with reports saying no signs of envenomation. On 14th, she developed sudden onset irrelevant speech. She was fluctuating. She was not understanding what the family members were asking and responded irrelevantly. She also required 1% support for ambulation and complained of blurring of vision on the right side, following which she took native medications and no allopathic treatment was considered. On 24th, she presented to our emergency department in the same state without any progression or regression of symptoms since 14th of December. Past history, she was treated with native medications for the above complaints, with which she did not have any resolution of symptoms, no symptoms of CTD features. Personal history, married since 7 years, 1 child, 6 years old, no history of abortions. Vital signs on arrival was pulse rate 86 beats per minute, BP was 100/60, respiratory rate was 20 per minute, saturation was 98% on room air, and temperature was 90 degrees Fahrenheit. General examination, edema of the left leg with warmth, no tenderness or redness, no bite mark was seen, no pallor, ictus, cyanosis, clubbing, or lymphadenopathy. On systemic examination, the positive findings were fluency. She decreased verbal output and new meaningless words, replacing with different words. Comprehension was impaired. Respiration was preserved. Cranial nerves was left prominent nasolabial fold. We could now examine her visual fields as she was not obeying the commands consistently. Power, right side upper limb and lower limb power was 4/5 with poor right side hand grip and right plantar for extensor. Summary, 36-year-old Mrs. X, homemaker from Gudiatam, presented with syndrome complex of unknown bite in the left feet, following which she had bilateral ptosis for 1 day, which spontaneously resolved. Then she developed an incomplete sensory aphasia with right UMN facial palsy and right hemiparesis and probable right-sided homonymous hemianopia. Probable neurotoxic snake bite because of bilateral ptosis, and clinical localization was a left temporoparietal occipital cortex because of incomplete sensory aphasia, right UMN facial palsy, right hemiparesis with right plantar extensor, and probable right-sided hemianopia.
1 second, go back. So the first comment is the left nasolabial fold prominent or the right is less prominent?
Left was more prominent.
So when you have facial palsy, will the normal side become more prominent or the abnormal side will become less prominent? So you must say the right side is less prominent. You should not say left side became more prominent. You're trying to say right-sided facial palsy. You should not say the left side will become more prominent. The right side become less prominent. If you have hemiparesis, is it motor or is it sensory?
Motor.
So which of these is motor cortex? Temporal, parietal, occipital?
So frontal with the
so you should be careful. It's good you put up. I'm very happy with your order of thinking and your differential diagnosis, trying to make localization. But if you say there is motor weakness, it has to be a frontal cortex. So it doesn't seem to be a small area. If you're saying that there is evidence of sensory aphasia along with motor weakness, it has to involve the motor cortex as well. So that you should be careful of that localization. So that's okay. Go on.
The differentials considered at this point were an unknown bite probable, a neurotoxic snake bite causing infarct, probable a thrombotic microangiopathy, a snake bite induced hypertension leading to watershed infarct, snake bite induced leukoencephalopathy, a reversible cerebral vasoconstriction syndrome, connective tissue disorders with CNS vasculitis triggered by secondary to toxins, cortical vein thrombosis, a space occupying lesion, tumor with hemorrhagic bleed. The investigations sent were hemoglobin of 11.3, WBC of 14,000, with normal platelets, neutrophils of 70, lymphocytes of 18, monocytes of 10, normal PTINR and APTT, normal renal function test and electrolytes, normal LFT. APLA workup was negative, ANA was negative, ANCA was negative, CPK was normal, with no schistocytes. Our patient, MRI brain with MRI was done, and it showed areas of gyral swelling, hyperintensity, diffusion restricted, and hemorrhagic involvement in temporoparietal occipital lobes, more on the left side with minimal mass effect on the left lateral ventricle. MRI showed bilateral MCA along with cortical branch attenuations. And CTO angiogram showed a mild paucity of cortical branches of left MCA with no features of vasculitis. So these were the MRIs for our patient. There are three case reports which showed a snake envenomation followed by Rcvs. A 22-year-old person with a common kite snake bite with a thunderclap headache from day 2. MRI showed multifocal segmental cerebral artery vasoconstriction, and she was started on nimodipine 60 mg Q6 hourly, paracetamol, and MRI on day 30 showed complete resolution of vasoconstriction. This was a similar complaints in all three patients. Rcvs, it's a reversible cerebral vasoconstriction syndrome, represents a group of conditions that shows reversible multifocal narrowing of cerebral artery with clinical manifestations that typically include thunderclap headache and sometimes neurological deficits related to brain edema, stroke, or seizures. These conditions are usually characterized by clinical manifestations that typically include a thunderclap headache, which is sudden onset peak intensity in 1 minute, with or without nausea, vomiting, photophobia, or phonophobia, and recurrence occurs for weeks up to 3 months. It's more of female predominance, 20 to 50 years of age with mean age of 42. Focal neurological deficits are seen in 88 to 43% population. Epileptic seizures are seen in 17% population. It is necessary to demonstrate the reversibility of vasoconstriction within 12 weeks to confirm the diagnosis. So the precipitants usually are postpartum state drug with vasoactive properties like cocaine, marijuana, catecholamine secreting tumors, autoimmune disorders like SLE, APLA, blood transfusions, temperature differences, baths too cold or too cold, air travel, COVID-19 infection, medications involving nasal decongestants, immunosuppressants, antidepressants, OCPs, indomethacin, or ergots. History of migraine increases the risk of bleeding complications in Rcvs. So pathophysiology is a transient dysregulation in the control of brain vessel tone, which results in multifocal vasoconstriction. And factors affecting tone are endothelial dysfunction, sympathetic hypostimulation, alteration of vascular smooth muscles by oxidative stress. So these are examples of a CT and an MRI which shows multiple vessel narrowing involving the branches of posterior and anterior cerebral arteries. And figure A is a superficial convexal subarachnoid hemorrhage along the bilateral posterior frontal lobes. So the diagnostic criteria involves multifocal segmental cerebral arterial vasoconstriction demonstrated by CT angiography or MRI or conventional catheter cerebral angiography. No evidence of any aneurysmal subarachnoid hemorrhage, normal or near normal CSF analysis, severe acute headaches, often thunderclap, with or without additional neurological symptoms, self-limited monophasic course without new symptoms 3 months after the onset, and angiographic reversibility of cerebral vasoconstriction 3 months after the onset. So there's a Rcvs2 score also, and if the score is greater than 5, it is positive for diagnosis of Rcvs with a specificity of 99% and a sensitivity of 90%. The complications involve epileptic seizures, ischemic strokes, SAH, and intraparenchymal hemorrhage. And these bleeding events occur during the first week and ischemic events later around the second week or third week. Management is a self-limiting condition. Calcium channel blockers like nimodipine and verapamil can be given. Intra-arterial vasodilation is indicated only for clear signs of clinical progression, and patients should avoid physical exertion, sexual activity, and Valsalva manure, and other known triggers of recurrent headaches for a few weeks. Laxatives and stool softener should be added. There is no control.
Yeah, 1 minute.
Yeah, there's no controlled trials for nimodipine, but there is observational data and expert opinions regarding the same. Treatment for our patient was nimodipine plus aspirin. Plan for observation for 6 weeks to 3 months, and repeat MRA after 6 weeks to look for resolution of vasoconstriction.
Okay. In the interest of time, we have 6 presentations today, so we'll take 1 question from the audience. Anybody would like to ask any question?
Do you think a snake visited this patient?
Yes.
Snake.
Probably neurotoxic snake bite, sir. A cobra or a
Cobra venom cause neurotoxicity. It acts on the neuromuscular junction. So, the patient has a stroke.
yes,
And has some evidence of vasospasm of the vessel.
yes.
So what is not clear is that how did the cobra venom cause this syndrome?
So
You have to have some logical explanation. The person had a stroke syndrome. Get a clear line.
So it's a complication of the vasospasm that the stroke developed for this patient.
There's no way that cobra venom can do this.
Yes.
It is why I'm saying that there must be some other explanation here in this case. So it is not a described complication of a cobra. I'm not sure. This patient clearly had a stroke, and strokes don't occur after cobra. Occurs after Rcvs.
Thank you, Reji. When you put up those slides of images from other places, from other textbooks or journals, we should give an acknowledgement at the bottom of each of those. This material will be shared online, then we should acknowledge those materials, right? Thank you, Reji. Well done. Let's give him a hand.
What may be the possible? There's something called neurogenic shock, which occurs after snake bite. It can happen even in a non-resident bite. So I don't know whether there was some major stress which caused some dysregulation of the brain, which causes vasospasm. It's also known in the reversible ischemic vasoconstriction. Maybe some other explanation may not be direct.
Thank you, Reji.